Hello and welcome to this webinar on developments in the management of PCL and multi-ligament knee injuries. My name is Chris Wallis and I'm the Asia Pacific Clinical and Education Manager for our OA and Injury Solutions. Today's webinar is going to be delivered in two parts. The first part I will deliver and I'll provide some background into PCL injuries and recent developments in PCL bracing. And I'll then hand over to our special guest, Luke O'Brien, who will look further into the rehabilitation of PCL injuries. The posterior cruciate ligament is the largest and strongest ligament in the knee. Its primary function is to restrain posterior tibial translation, but it also has a secondary function in assisting with rotational control and varus and valgus control of the knee. One of the important features of the PCL is it has very good blood supply. And this blood supply gives it an intrinsic ability to heal. Structurally, the PCL is made up of two distinct bundles, shown here on the right. So the larger of the two bundles is the anterolateral bundle, and then we also have the smaller posteromedial bundle. These bundles are named after their origin on the femur and their insertion on the tibia. So the anterolateral bundle starts further anterior on the femur and inserts further laterally on the tibia. I mention these two distinct bundles because in Luke's presentation, he will mention about surgical reconstructions, and these reconstructions can be either done as a single bundle, where just the anterolateral bundle is reconstructed, or a double bundle. And this will depend on injury pattern, other structures affected, and surgeon preference. This is a really nice, quick animation that shows what happens to the cruciate ligaments through knee range of motion. And I guess the key points I'd like to make here is you'll notice that the PCL is relaxed at extension and comes under tension as the knee flexes. Conversely, the ACL is more under tension towards extension and relaxes as the knee flexes. So graphically, this illustrates what we just saw in the animation. So the anatomical loading of the PCL, so low loads at low flexion angles, increasing with knee flexion angles up to a maximum tension, which is reached around 100 degrees of knee flexion. The most common mechanism of injury for an isolated PCL injury is what's known as a dashboard injury. And this is where a direct blow to the anterior tibia is sustained whilst the knee is flexed. So in the previous slides, we saw that the PCL is under maximum tension in flexion. So we've already got a structure that's under tension, and if we sustain a blow to the anterior tibia, this can be enough to put a short, sharp stretch on the PCL and cause it to rupture. In the world of AFL, this is an injury that's often termed as the Ruckman's curse. And you can see when you've got two players coming together at high velocity in some cases and with their knee flexed, you can see how a PCL rupture could occur. Similar to what the dashboard injury looks like. PCLs can also be injured via other mechanisms such as hyperextension, hyperflexion, or rotational injuries where there's associated varus or valgus stresses. When there are multiple mechanisms of injury, we'll often see multiple structures damaged, and this is where we'll see multi-ligament or complex knee injuries. As far as grading, PCL tears are graded based on the extent of disruption to the ligament plus or minus the degree of posterior tibial translation. So a very simple grading would be, as you see here, grade 1 through to grade 3, from a partial tear through to a complete rupture. Injuries can also be diagnosed using kneeling stress X-rays, and an example of this is seen on the bottom right of the screen here, where the left-hand diagram shows posterior translation of 5.2 millimetres, and this just shows a relative side-to-side difference of 10 millimetres of posterior translation. As a rough treatment guide, and this is by no means definitive, but gives you a rough idea of treatment options. For an isolated PCL where there's less than 8 millimetres of posterior tibial translation, these can be managed conservatively with functional rehabilitation and a brace. This will also depend on patient characteristics such as the patient's age, activity level, etc. But that's a rough guide. For those where we've got greater than 8 millimetres of posterior tibial translation, these are generally treated by PCL reconstruction. And when there are multi-ligament injuries where the PCL is involved, these again will be managed surgically. Compared with ACL injuries, PCL treatment outcomes have historically been lower. One of the problems historically with the PCL is that it has a tendency to heal in an elongated position, and this can be both following conservative and post-operative management. So historically, we've seen suboptimal outcomes, and generally it has been resultant ligament laxity because of this stretching out of the PCL. So Hamoud concluded in his article that generally good results are reported after PCL reconstruction, but long-term studies suggest that normal stability in the majority of patients is not restored. So if we've got a patient that has chronic posterior laxity and associated instability because of this PCL lengthening, this will lead to medial femoral condyle and patella cartilage degeneration with resultant chronic pain and knee OA. So not a great outcome. So the reason that the PCL has this tendency to heal in an elongated position is as simple as gravity and dynamic load of our own anatomy. So in a supine position, just the weight of the tibia alone is enough to provide a long passive stretch to the PCL. And then once we initiate hamstrings, the dynamic load of the hamstrings pulling on the tibia creates or causes a posterior translation moment in the PCL injured knee. So that's why I'm sure Luke will touch on the importance of quad strengthening in the rehabilitation following PCL injuries to counter that posterior moment. Historically, flexion limitation has been a key part of management of PCL injuries. And I guess it stands to reason when we know that the PCL comes under greater stress as flexion angle increases. So historically, limiting or preventing flexion has been part of the injury management. But as in a lot of injury rehabilitation, those periods of extended immobilization are not ideal because of the concurrent issues of muscle atrophy, loss of range of motion, etc. So that's why it's becoming more and more important and accepted that we want early mobilization in a protected environment. This slide highlights a few of the key factors required for tissue healing. So when we think about the structure itself, we need good blood supply, which we know the PCL has. And given that we're talking about a ligamentous structure, This is a structure made up of collagen fibers, and collagen certainly has the ability to repair and proliferate. So we're in a good place with the PCL. Functional rehabilitation is becoming more and more important for tissue healing, where we're not just having those lengthy periods of immobilization, but we're doing rehabilitation specific towards the function of that injured structure. And obviously time and patient compliance are key functions as well. But where we have the option from a bracing perspective to make a big difference is to provide a biomechanically stable environment for the injured structure to heal, and to provide anatomically and physiologically correct loading to the injured structure. So our guest presenter, Luke O'Brien, was involved in a study back in 2011 that looked at an historical perspective of PCL bracing. So in this article, they highlighted a number of reasons for bracing PCL injured knees. So for those knees that have a history of being ligament deficient, you may provide external stability to the knee through a functional knee brace to replicate the function of the PCL, which has been lost through injury. They also highlighted a couple of preventative or prophylactic reasons why you might brace the injured knee. So to prevent re-injury and to reduce the development or progression of OA for those patients who have got a PCL deficient knee. But they also highlighted the need to protect the reconstructed ligament and prevent graft elongation for those surgically managed cases, or to assist ligament healing in the non-operative cases. So these two reasons are really the reasons are rehabilitative reasons. So historically, very few braces have been specifically designed or developed for the management of PCL injuries. So often we've seen ACL braces that have then been adapted to function as PCL braces. So up until recently, we've had really braces that act as barriers to normal motion. So these could be things such as our post-operative range of motion knee braces. So where we're trying to limit normal motion to try and protect the structure. And more recently, we've seen the development of a couple of braces that apply static load to try and protect the PCL. But when we remember that the PCL is a structure that comes under varying forces with varying knee flexion angles, if we provide a static load to try and protect the structure, we're only providing a force that's correct at one point during our knee range. So from their study, it was concluded that a properly designed PCL brace should apply correct anatomic joint forces that vary with knee flexion angle, and also provide some adjustability. And this is where the idea of the Rebound PCL brace came, a brace that was able to adequately support the PCL throughout full range of motion. So the Rebound PCL is designed to optimize the rehabilitation of both surgically repaired or conservatively managed PCL injuries. It can be used on isolated PCL injuries, or it can also be used on multi-ligament injuries with PCL involvement. Some of the key features of the Rebound PCL I'd just like to point out are that the brace has long lever arms. So much like a standard range of motion knee brace where we want long lever arms to provide maximum stability, the Rebound PCL is similar. So unlike a functional ligament knee brace, which are much shorter, this is a much longer brace. We have range of motion adjustable hinges, and we importantly have the dynamic posterior tibia loading via the cable, which you can see, which is adjusted by a dynamic adjustable tension system. So bottom right hand of this screen, you can see the dynamic tensioning system, which sits on the proximal posterior calf. And we have 3 different shear knobs which are able to be tensioned to varying loads. And Luke might expand on this a little later in his presentation regarding the practicalities of that. So essentially, once the load is set, it will follow this force curve, and it will depend on which knob is used as to the starting point, but the profile of this force change will be the same. So essentially, we've created a brace that is able to maintain the PCL in a shortened position throughout knee range. So this is a product that will allow rehabilitation to occur earlier, and in many cases to be a little more aggressive. So starting with maintaining range of motion and muscle strength. So it truly is providing functional rehabilitation to the patient to maximise the outcome. In 2014, there was a biomechanical study done on the Rebound PCL, which had a look at the forces and how these compared to the reconstructed PCL. So this table or graph shows the forces generated during squatting. So the top line is the forces subjected to the reconstructed PCL graft. The line just below are the forces generated by the Rebound PCL. And then we've got a straight line, which is a static force PCL brace. So pleasingly, we've got a brace that is able to closely mimic the forces that the reconstructed PCL is subjected to. So why is this dynamic force important? So when we think about PCL injuries, whether it's an isolated PCL or part of a multi-ligament injury, by having a dynamic force that increases with flexion angle, it ensures that the PCL is optimally supported at all range of motion angles. When we think about the PCL as part of a multi-ligament injury, it also ensures that if the ACL was involved in a multi-ligament injury, that it is not overloaded in the early stages of knee flexion. So remembering that the ACL is under more tension as we're back towards a fully extended position. So the last thing we want to be doing is providing an aggressive anterior draw as the knee gets back towards an extended position, which would potentially put too much stress on the ACL and may cause issues there. So if we had a static force brace and we were setting a force that was at the mid-range, we are potentially overloading an ACL if the ACL was involved in those early flexion angles. Then for our PCL injuries, either isolated or multi-ligament with PCL, we're really not providing adequate load of the PCL when it's at its most vulnerable at those higher knee flexion angles. So this has been a bit of a background on PCL injuries and a bit of an introduction into dynamic force PCL braces. And hopefully what I've been able to demonstrate is that with the Rebound PCL, we've got a product that is able to provide a biomechanically stable environment for that injured PCL to healing. And it's also a product that is able to apply anatomically and physiologically correct loading. So two of those key components of tissue healing have been able to be addressed. It's now my pleasure to introduce our guest speaker, Luke O'Brien. Luke is an Australian-educated physiotherapist who's been based in Vail, Colorado since 2002. Luke's the Vice President of Clinical Physiotherapy at the Howard Head Sports Medicine Clinic, and he has a focus on lower extremity musculoskeletal disorders with a specialisation in treatment of the knee. Luke's now going to provide us some insight into his experience managing PCL injuries, including some tips to maximise the clinical outcomes for patients. He'll also share with us the practicalities of how the Rebound PCL has become an integral component of their PCL and PCL multi-ligament injury rehabilitation protocols. So I'll now hand over to Luke.
Well, Chris, thanks for the opportunity. I thought today we'd take the opportunity here to discuss the posterior cruciate ligament, one of the most probably common overlooked ligaments within the knee, largely because it's not frequently injured. And so I wanted to take the opportunity here to discuss some of the things that I've learned through being here in Vail and the volume of PCLs, but also total knee injuries that we see, and some of the tips and pearls and pitfalls also that we've experienced, and hopefully provide some little bits of information that you can take back to your clinical practice to put into play, and maybe also change how you think about managing patients with PCLs. So to give you a little bit of background about myself, I'm a physiotherapist. I was educated in Australia. I've actually been in Colorado, United States here for about 17 years. So this here is Vail. This is the town that I live in and the place that I practice. This is during winter, which is probably 5 or 6 months of our year. And so this is a photo that shows really our ski area and some of the mountains that kind of cradle the ski area. But, you know, not surprisingly, I think we're about the third largest ski area now in North America. We probably on an average day see about between 10 and 15,000 skiers per day on this mountain. If it's a really busy day, so around Christmas, we're probably up over 20,000. And so just as a function of having 15,000 people on skis sliding down a hill that has littered with trees, as you can see, we see a huge amount of knee injuries. And so as a function of that, the hospital that's in the village of the ski area set up really quite a large orthopedic practice. And so this is just a photo of our PT clinic, not because it's better than anyone else's or it shows anything remarkable, but within this PT practice, we see almost 40,000 patient visits in a year. And within those 40,000, we can see, or we have direct access from our emergency room for every knee injury that gets admitted from our ski area from winter. And so it's not unusual for us to see up to 15 ACL injuries a day as a result of the trauma that comes off the mountain and our proximity to it, and then some of the specialized care techniques that we've developed because of the high volumes of knee injuries that we see. And so to bring this back to PCLs, one of the big things that happens in our practice is we see very few kind of traditional PCL injuries. So, there's not very many shin-to-shin contacts as a result of playing football or AFL. There's not very much tackle football going on that's causing PCL in our community. And there isn't very many dashboard motor vehicle accidents. What we typically see is skier versus tree. And it's those multi-ligament knee injuries that have either a PCL basis or a partial PCL involvement in the knee injury. And so we got, as I said, a large volume of PCL injuries as a result of ski trauma. So one of the things that I wanted to lead off with here is really an agenda. And so this would be the third slide that we've got here showing the outline for today's presentation. And so I wanted to really cover about 6 areas. And first one being the historical management of PCL and some of the challenges that have kind of occurred as a result of those management techniques. I'm not going to cover the detail of surgical repair because it's not what I do, and so I'm not the expert to speak on it. But I wanted to talk really about how we've evolved surgical management and then how we protect and the repair and how that leads to different restrictions throughout the continuum. Briefly touch on acute management, because what we do acutely really sets up the opportunity to have a great outcome. And then we'll talk about dynamic bracing and how the evolution of bracing technology has really been able to positively affect outcomes in PCL management, both conservative and surgical. And then one of the big challenges in PCLs is that surgically, these are long recoveries. They might be 6 to 12 months. And so how do you go about planning an effective rehabilitation strategy to ensure that we get an outcome that we want? And then largely, I'm going to present on our clinical outcomes. So what we have through our surgical techniques and then our post-operative management, these are the results that we get. And take it from there. So we'll move to the next slide. So this is a study that I pulled that presents data from this year. So if we were to talk about PCL traditionally, PCLs have been managed conservatively for the most part as a gross generalization for two reasons. The first is that when they're managed conservatively, a lot of these people are able to continue their activities of daily living or return to high-level function pretty well. And so this is a study that really emphasizes that point. So 46 patients with MRI-confirmed grade 2 or 3 PCL injuries that were all managed conservatively. And they were reviewed until they returned to sport, and then again at 5 years after they had their initial injury. There was a 16-week was their average time to return to competitive sport, and 91% were playing at the same level or higher after 2 years, and then 69% were still at that same level 5 years after sport. When you look at those outcomes, you say, you know what? Why would you ever consider doing surgery on a PCL? These patients do really well. They return to sport at a very high level, at a very high rate. And so why do we do anything about it? And then the second component here is that surgeries traditionally didn't always do great. And so on our next slide here, this is a quote that I took from a paper that was published in 2010. And the quote reads, generally good, and this is a quote that is on single-bundle PCL reconstruction. And so generally, good results are reported after PCL reconstruction, but the long-term studies available suggest that normal stability in the majority of patients is not restored. So when you combine these two pieces of information, people managed conservatively return to high levels of function, and that the people managed surgically may still have good outcomes, but the purpose of doing surgery is primarily to restore stability. And so single-bundle PCLs are not restoring stability at any rate that would be acceptable either to a surgeon or necessarily to the patient. So all that's great. The problem is that PCL-deficient knees have a natural history of developing medial and patellofemoral compartment osteoarthritis. And this is well known and well documented into the literature, that 5 to 10 years and sooner in some instances where they're competing in high impact activities, that they would develop osteoarthritis. And so one of the things that I've learned in my practice is that very, very few patients come to us seeking care for short-term fixes. And that people will come in and say, you know, I've got an unstable knee, and their motivation for seeking care is not only do they want to have an active knee, but they want a knee that's going to survive their life. And so when we begin thinking about care pathways for these patients, to be able to say, you know what, we can manage this conservatively, and you're going to be able to go back to your sport in 4 months' time, and you're likely going to be able to play it for at least 2 years. But in 5 years' time, you're going to develop osteoarthritis, and maybe 10 or 15 years' time, you're going to need a knee replacement. It's probably an unsatisfactory care pathway and outcome for a patient with a PCL injury. And so that really is the catalyst to begin to examine, well, what needs to change in the surgical technique and in the post-operative management to ensure that patients with PCL injuries get better long-term outcomes after their injury. And so I don't want to touch too heavily on this because I'm going to talk about our outcomes at the end, but this is just a technique and outcome paper published by Rob LaPrade. I believe it's 2010. And what this technique really changed is this goes to a double bundle PCL reconstruction. So previously, almost all PCLs were a single bundle in nature. And so this really goes to creating a larger footprint. It's more accurate based on the anatomical footprint and more accurately reproduces the function of the PCL. And so surgical management, and we'll discuss later on, likely should move wholly towards doing a double bundle PCL reconstruction. So we don't frequently think about the PCL, right? It's not very frequently injured and it's not always the top of our mind. So in terms of its anatomy and function, it can be a little bit of confusing to some clinicians or practitioners. So this is a video that we've shot in our biomechanics lab, in our cadaver lab. And so this is the PCL that you can see here. The posterior medial bundle and anterior lateral bundle are highlighted. And then here's the posterior meniscofemoral ligament. And so this will shoot through a few different views. And so this is just showing tension, inflection, and extension from posterior aspect. And then we'll have a dissection that will come up here shortly. And what I really want to demonstrate in that dissection is how the PCL gets tension in flexion. So here you go, you've got a PCL ligament that's pretty evident. So the anterior lateral bundle has a massive footprint, and then the posterior medial bundle, a small footprint. That's really taking up that whole wall, or almost that whole wall of the femoral condyle. And so you can see here as the femoral condyle, or the knee rather, moves into flexion, that tension on those bundles increases, and that as you move into extension, the bundles become more lax, so the tension moves away. So if you accept that it's not satisfactory to just assume that all PCL deficient knees should develop osteoarthritis, and that surgical management likely is a good option for some of these people, and that double bundle is the way to go, then we have to have some kind of outlines surrounding our postoperative restrictions. So the number one thing after all PCL reconstructions is we've got to protect the reconstructed ligament. And so these are some guidelines that we use in our practice, helping ensure that the integrity of the ligament is maintained while we restore joint range of motion. So just highlight some of these things. So first of all, range of motion. We would restrict all of our PCL or PCL-based multi-ligament injuries to 0 to 90 degrees for 2 weeks. After that 2 weeks, they are then permitted to go to full range of motion. This is done all passively and prone. We do it prone so that we mitigate the effects of gravity, pulling the tibia into a posterior translation position and elongating the reconstructed PCL. The range of motion, 0 to 90 for 2 weeks, all done prone, and then after 2 weeks, going for full passive range of motion, it's still completed in the prone position. We treat all of these PCL reconstructions non-weight bearing for 6 weeks. We've currently started a randomized controlled trial looking at the effects of weight bearing or early weight bearing versus non-weight bearing. We're still in the early enrollment part of that, and so we haven't been able to prove that early weight bearing does not negatively impact graft elongation, although that is our hypothesis. So right now we manage all of our PCL non-weight bearing for 6 weeks. The bracing. Immediately post-op, all of our PCL or PCL-based reconstructions are immobilized in a knee immobilizer. And so one of those Velcro strap kind of knee immobilizers that they wear basically 24/7, other than 2 times a day when they come to physical therapy or physiotherapy for their recovery stuff. Now we do that primarily because immediately post-surgery, there's a relatively large amount of swelling, and so it doesn't always lend itself to being able to be fitted with a dynamic brace. What we will do in our first week is try almost daily to determine suitability of moving from the immobilizer into a Össur Rebound PCL brace. Now, one of the things that I would say is that we do that after the femoral nerve block has been pulled. So in our practice, people are discharged from the hospital with a kind of a portable femoral nerve block. So that comes out after 3 days. When people can accurately report their sensation, their swelling allows it, we would then put them in the Rebound PCL brace. And they would wear that PCL brace basically 24/7 for 6 months after their surgery. And then the fourth point on here is hamstrings. So we don't allow isolated hamstring contractions for 16 weeks. So isolated hamstring, particularly in a position of knee flexion, is going to have a posterior draw effect on the tibia. And so that would obviously stress the immature grafted PCL. And so we want to mitigate the risk that that graft stretches out, and so we avoid isolated hamstrings. We also don't allow any unsupported knee flexion. So when we're doing we made a point earlier that we do all of our range of motion prone. And so even after 6 weeks, when they begin weight bearing, we try to keep that prone position for range of motion for the same reason of avoiding that posterior tibial translation. Those are the postoperative restrictions that we put in place. As I said, PCL is by no means as well researched as ACL. And so we're doing some work here surrounding weight bearing, but it's likely that these restrictions will likely change and evolve over time as our knowledge of what we can do and likely how bracing can help us mitigate the risk of graft elongation and likely lead to change in these restrictions. So the next slide we got here are our acute goals. So the patient has now had a reconstruction, we know what our restrictions are, and they then present to you in the clinic. And how do you go about managing these patients? And so the first thing that I'd advocate is the goals for PCL reconstruction largely are exactly the same as an ACL-based knee injury or a meniscus root or meniscus repair injury. And they are that we need to restore joint homeostasis as soon as possible. We need to manage the scarring process. We need to restore joint range of motion. We need to get a great quad. And we need to create a plan that the patient understands and is engaged in. And so with those acute goals in mind, this really is kind of the fundamentals of the exercise program that I would put into place. So day one range of motion, day one after surgery. We would do all prone passive as we previously discussed. We have a heavy emphasis on patella femoral mobilization. I'm going to discuss this in a little detail with a few further slides. We would manually put someone in supine, calf is supported by the table, so we don't need to worry about the tibial translation issue. And we would mobilize through the quad, the patella, and the patella tendon, and then also superior, inferior of the patella to maintain the integrity of the interval spaces. We don't begin bike until week 7. And the reason for that is we have someone non-weight bearing. Bike is not a non-weight bearing activity, so we want to wait until our patients are weight bearing before initiating stationary bike. Once the femoral nerve block is out and the patient begins to have restoration of their sensation and muscular function, we have a pretty heavy emphasis on teaching quad initiation drills. So in our hands, that has very little to do with creating movement of the knee, but a lot to do with teaching the superior glide of the patella. And in our experience, if you're able to teach the patella glide before you then teach knee extension, then you have great success and the patient is able to really understand and independently activate the quad in an appropriate manner. And then joint homeostasis. So obviously, edema and swelling in inflammatory management, we use all of the typical modalities available to us surrounding ice and elevation. We would use vasonomatic compression, so a Normatec boot or something similar. And then we got a discussion surrounding responsible load management. So, we're in a tourist town. It's got plenty of things for people to go out and see and do. And, a lot of people have paid a lot of money to come to Vail for a holiday, and then they experience a catastrophic knee injury, and they don't want to sit in a hotel room. And so they'd like to go out to restaurants and bars and that kind of stuff. And so we spend a pretty reasonable amount of time educating people that you need to be on your feet for the things that you have to do for life, but you shouldn't be on your feet for more than that. And so the negative effects surrounding pain management and joint effusion of when they overload their joint by too much time up and on it is what we're trying to avoid by doing that. I want to kind of change tactics here a little bit in where we're going with this presentation. So it's all well and good to say, you know what, we're doing DoubleBundle PCL, we're going to get great stability, we're doing all the things right. But things happen. And one of the big complications from any large base knee surgery is arthrofibrosis or joint stiffness. So I wanted to share with you, and admittedly, this is somewhat of an extreme case. This is a patient of mine for a number of years ago who was a debt collector. He had a knee dislocation, a PCL-based knee dislocation, a multi-ligament knee injury on a beach. And so he underwent surgery in Florida and then presented to our clinic with postoperative stiffness. And so this is, if I can get this to play. As you can see here, this is his total arc of motion. So you're looking at probably, 10 degrees lacking extension, and then maybe a 40-degree total flexion angle, maybe 45 with overpressure. And so this gentleman has gone from a situation where he had a grossly unstable multi-ligament knee to having surgery on that knee to reconstruct and recreate stability. And then he was immobilized after surgery. So he had 4 weeks where he didn't move at all. And so you have a large inflammatory response that lays down a ton of scar tissue. And the result is that he went from an unstable knee to essentially a fused joint. And that is, so far away from what is an acceptable functional outcome from a PCL-based multi-ligament injury. And the consequence of this is it changed this guy's life. He's not going to be able to do many of the things that he wants to do because of the outcome from the knee injury that he sustained. So that leads me into scar. And so to really understand arthrofibrosis and the symptoms related to arthrofibrosis, you've got to understand the importance of the joint spaces in the knee. So underneath the quad tendon, there is the suprapatellar pouch, which is about a 3-finger length pouch from the superior part of the patella and to the point where the quad tendon becomes attached to the femur. And so that pouch, then the anterior interval is the space underneath the patellar tendon to the tibia and the anterior border of the ACL. And so on this model, you can see that there's kind of the space in front of the tibia where there's no fat pad is the anterior interval, and then just underneath the quad tendon near the femur is the superior patellar pouch. Now, the purpose of these spaces is really quite simple. When you flex your knee, your femur and your tibia move into those spaces. That's how you bend. And so when you go into extension, you get separation from the tendon from the bone, and those spaces open back up again. And so you can, as I said, you can see here the femur moving into the superior patellar pouch and the tibia moving into the anterior interval, and when it goes straight, those spaces open back up. And when you have scarring, almost 100% of the time, scarring exists in those spaces and has a tendency to tether the tendons, both quad and patella, to the tibia and femur. And so you lose that joint volume, and then as a consequence, you lose the ability to flex and extend the knee in the manner that you want. So the consequences of joint scarring and tethering those the patella tendon and quad tendons to the femur and tibia respectively, is that you create an environment of increased contact pressure. And so it's not only increased patellofemoral joint contact pressure, but also tibiofemoral joint contact pressure. And if you think about the natural history of, particularly in the ACL literature, about ligament reconstruction and development of osteoarthritis, 10 years after injury, and you think about how scarring increases joint contact pressures, you can see there's a direct relation. So the second consequence is that anterior interval scarring decreases the momentum of the extensor mechanism. And as a consequence, it has a direct result on decreasing the force that the quad is able to generate. And so when you begin to look at long-term quad deficit, not only is this likely a consequence of not being able to redevelop a normal quad bolt, but it also is a consequence of reducing the momentum and the leverage benefits of that momentum. And then lastly, when you think about the incidence of anterior knee pain post all knee surgery, it's not always just a patellar tendinopathy that exists. This is related to an increase in scar and an increase in joint contact pressure. So I mentioned earlier that one of the key things that we implement immediately post-surgery is patellofemoral mobilization, something that we perform in the clinic and something that we encourage our patients to perform, so that we're doing it maybe 5 to 10 minutes, 3 to 4 times a day. So this is a video that we took in our cadaver lab, just as the influence that joint mobilization can have on the spaces that we just described. So this is the superior patella pouch. And you can see I'm not doing anything particularly aggressive here, but you can have really quite a marked impact on that pouch. And this is the anterior interval. You see the fat pad and the medial femoral condyle on the anterior border of the ACL. Here's the trochlea. And so I wanted to show you that so that you can get an understanding that mobilizing the anterior knee has a direct influence and effect on the compartments that we want to influence, to minimize scar and to make sure that any scar that does develop is loose and mobile and doesn't restrict the anterior knee mechanics in any way. The next slide here, one of the largest influences in improving PCL surgical outcomes in the last few years has been the development of dynamic PCL braces. And really the first paper that identified this was Jacoby in 2010. And so they looked at 21 patients at 1 year after injury and then 17 with 2-year follow-up. Their initial mean posterior tibial sag was 7.1 millimeters. And the way that they managed these patients was they used a PCL jack brace full time for 4 months. And what they found was after 12 months, that there was that 7.1 average posterior tibial sag was reduced to 2.3 millimeters. And really the outcome of that was it was able to demonstrate that the PCL has intrinsic healing capacity if the knee is reduced in a physiological position, and it can heal with less attenuation. But just because someone comes and presents with a grade 2 PCL and has a firm end heel that they're lax, doesn't mean that they're always going to heal lax. And so using a dynamic PCL brace to provide an anterior draw force can provide benefits in improving knee stability. And more recently, in a study published this year, earlier in the presentation, we outlined that the natural history of PCL injuries is developed patellofemoral and medial compartment osteoarthritis. And so this paper was able to show that the use of the dynamic anterior translation brace reduced patellofemoral joint contact pressures in PCL deficient knees. And their conclusion was that it may have a role long term in people that, for whatever reason, don't want to go down a surgical path. The use of this brace either in activities of daily living or in return to sport situations may be able to mitigate the onset of osteoarthritis. This is a biomechanics study not done in people, so we've got to understand that there's probably, in theory, this works well, but may not be borne out yet in human populations. So in our management of PCL injuries, all of our patients will receive a dynamic PCL brace. And so we use the Össur Rebound PCL brace, and we would use it for 6 months in all of our conservative managed cases. So this would frequently in our practice be grade 1s or grade 1 isolated, which is not very common. Most PCL, probably in our setting at least because of the traumatic environment, grade 3s, and either grade 3s in isolation or grade 3s combined with a posterior lateral corner or multi-ligament knee. So in the post-surgery environment, we've mentioned this early, all of our patients use an immobilizer post-operatively, but then as soon as they're able to, we put them in an Össur Rebound. And then we use that full time. So they sleep in it at night. They do their functional exercises when they begin doing their strength programming. And they use that all the way through 6 months. And then they return to sport. We would transition them to a CTI brace with a PCL strap. Now, the big difference here is that the Rebound brace offers increasing amounts of anterior translation to the tibia as flexion increases. So in the cadaveric slide that we showed earlier, we noticed that the PCL was on tension at greater degrees of flexion. So the Rebound brace will increase its anterior translation force as knee flexion increases. With the CTI brace, it is just a constant anterior draw force. It doesn't increase. But we feel that at 6 months, the ligament is sufficiently matured that we no longer need that the dynamic PCL support. And so we feel comfortable using the CTI brace with the PCL strap for return to sport activities at least through 12 months after the reconstruction. Now, in terms of using kind of the specifics of the brace, so there are 3 different tension settings that we utilize too frequently. So the first one is the level 4 setting. So this would be the black key. And the only time that we utilize this is for very small patients, so kind of your petite females, or patients that have significant amounts of post-operative pain. So if the brace is able to fit, but the tension on the brace is too much discomfort for the patient to tolerate, which is rare, we would use this level 4 setting. Almost all of our post-operative patients use the level 7 setting, so it's the gray key. And so we use that, that's what they're in immediately when we fit them in the brace. And they use that setting all the way through 6 weeks. And then at 6 weeks, when they begin to transition into or weaning off crutches and transition into full weight bearing, we will increase that tension using the white key to the level 10 setting. There are 2 range of motion settings that, or I guess stops that we utilize. So we will go use the 0 to 90 stop for the first 6 weeks, and that marries up with the joint, the 0 to 90 restriction. And then the second, after that, we move that stop to 105. And the reason we do this is to allow patients to spin on a bike. And I know most of you are going to look at me and say, well, 105 isn't enough range of motion. But at least what we have found is there's probably more flexion. So even although the brace may stop at 105, it allows the knee to bend beyond 105. So 105 is has been a reasonable stop for us. As we had mentioned before, with their return to play, we'll make a transition into a CTI brace with the PCL attachment. And then time frames, this is really important. So there's no great value in using a dynamic brace if you're going to take it off for vast expanses of the day. So we encourage our patients to wear this basically 24 hours a day for 6 months. The only time they're coming out of it is when they're doing rehab with their physio and they're doing their prone range of motion activities, but otherwise they're wearing the brace. And then we make that transition to when they begin functional strengthening. So when they begin their squat progressions and they move into leg press and functional activities. They are wearing this brace while they are doing those activities. And our experience has been by the time they get to that, maybe 8, 12, 10 weeks out, they're so used to wearing it and moving in it that it isn't inhibitory in any way. So I want to change tack here and talk a little bit about one of the challenges of managing people with PCL reconstruction. And that is that these are long-term recoveries, right? These are not people generally that are going to return to play at 3 months or 4 months. And so in our hands, this is a 9 to 12-month injury. And so how do you go about determining when it's appropriate to begin different phases of rehab, and how can you create a coherent plan that patients are able to understand, buy into, and help guide you through the rehabilitation process? And so by no means am I going to present anything that is, maybe I should say better. I think this is what I use. It's something that I found helpful. Maybe it's something that you'd be able to use in your practice. But it's based on the concept of periodization. And so we all know from the strength and conditioning literature that periodization really is about having specific training characteristics to develop the physiological component that we want to develop. And so in rehab, periodization makes, in my opinion, absolute sense. So it makes physiological sense from the standpoint of you've got type 1 fiber that atrophies predominantly following injury. And therefore, the logical conclusion of that is that you need to have a component of muscular endurance development to counteract that atrophy and negative influence on type 1 fiber. And so while there's little information in the rehab literature regarding the optimal design of resistance training, there's a ton while there's little in the rehab literature for injured athletes regarding the appropriateness of periodization, there's a ton in the strength and conditioning literature that shows that it's a safe, effective way of overloading specifically and developing appropriate physiological characteristics. So when I think about the kind of the periodized phases that I want to develop throughout my rehab plans, there are 9 that I try and plan for. And so these 9 you can see on your screen. They got range of motion and protection. If the patient is non-weight bearing, then I need to have a component of increasing weight bearing tolerance. And then I go through the muscular strength characteristics of endurance, strength, and power, initiating a running progression, speed and agility, a time to return to training, and finally return to play. So in a PCL reconstruction environment, this is the time frames that I have kind of just arbitrarily allotted to each characteristic. You can see that I've got about 6 weeks for range of motion protection. Now, if a patient gets all of their range of motion back relatively smoothly, then I would progress on to the next one. I got 2 weeks here where we focus on increasing the weight-bearing tolerance. And then I like to allow 6 weeks to develop or fully develop endurance, strength, and power. 4 weeks in my hands is appropriate for most running progressions, but I would tailor this based on the amount of running that an athlete needs to return to their sport. So obviously, a soccer player is going to be completely different from an NFL lineman and a baseball player. And so those running characteristics would determine how much time I spend within this running progression. Same is to be said for speed and agility, but roughly 4 to 6 weeks in my hands is an appropriate time frame in there. 4 weeks in return to training, and then lastly, a return to play. This is a plan for about a 9-month return to play. Now, in the conservative management of PCL, so if you've got someone that has a grade 1 or maybe a grade 2 that is being managed with a dynamic knee brace, these numbers are completely arbitrary, but this is what I would use. So I don't have the weight-bearing tolerance because we're not going to protect them in a non-weight-bearing fashion. But these conservatively managed PCLs follow really the same principles. They need to go through the same levels of development. They're going to have atrophy because of their initial injury. They need to develop a muscular strength and endurance base. And then finally moving through the same kind of parameters that we discussed for the post-surgical PCL patient. So one of the things that, particularly in the ACL literature, is being borne out is the importance of functional testing. And so there's a huge amount, particularly in youth and adolescents, about the risk of re-rupture and re-injury on the contralateral side, particularly for those that either return early or do not pass functional tests. And so I wanted to share with you what we have been doing in our clinical practice surrounding criteria-based progression. So one thing that we have moved away from is the idea that you do this grand test at the end of someone's recovery. And the reason that we have done that is, one, it doesn't provide any information or guidance through the recovery process. And two, if someone doesn't pass the grand test at the end, you wanted to know that information 3 or 6 months earlier so that you could have made adjustments to their treatment plan and program so that they will pass at the end. So what we have begun to put into play here is small chunking the rehab testing process and match up with the phases within our periodized plan. So we've got kind of 3 components here under range of motion. We want to have passive range of motion greater than 130 degrees. We want symmetrical active knee extension, and then patients being able to ambulate for 15 minutes. Now that's completely an arbitrary number, but what we kind of came to is that if you can't at least walk for 15 minutes without an increase in pain diffusion in your joint, then you have no business beginning to initiate a weight-bearing strength program. But typically you'll be on your feet for at least 15 minutes. So you can see here kind of measures. So we've got measures of quad strength and the criteria for that. One of the things that I wanted to point out is we've begun using the Dorsey system, or really any IMUs, to begin to quantify quality or movement quality. And we feel that that's an important factor. So instead of just using our eyes to say, yes, that's your alignment looks good in a squat or a box drop, you don't fall into 7 degrees or greater of dynamic valgus. But having an IMU that's able to absolutely quantify the quality of movement has been very helpful. So you can see the parameters here for muscular endurance, 80% on a quad index, anterior reach on a Y balance of less than 8 centimeters difference side to side. We use almost exactly the same, or exactly the same measures with the acceptance of the Dorsey box drop under our strength parameters. With power, we moved to single leg to double leg hop test, and then Dorsey vertical hop. And what we're looking there is symmetry in flight time, how much time a person spends off the ground. And then we're utilizing agility T-test and then average ground reaction force on clear people from the running phases. So I want to tie this all together to really put into perspective what our outcomes have been utilizing a DoubleBundle PCL with the range of motion restrictions that I've outlined, with a PCL Rebound brace, and then using under the rehabilitation principles of restoring joint homeostasis and range of motion and minimizing joint scarring, and then moving through periodized strength phases before returning someone to play. So this is unpublished data of a paper that we are getting ready to submit. It's of 100 PCLs that are either isolated PCLs or PCLs in combination with other ligament injuries. You can see here, this is a table that shows our preoperative outcome scores and our postoperative outcome scores. So this probably isn't very surprising to most of you. You can see here Lysholm increases from essentially 50 to almost 80. Patient satisfaction goes from a 2.5 to a 7.5. The Tegner increases from a 2.5 average to a 5.1. So those outcomes are good and subjective and things that we would expect for someone that's going from an unstable knee to a stable joint. What gets more interesting, I think, is when you begin to look at isolated PCL with multi-ligament. And what the literature is showing, and not just us, is that there really is no significant difference in a multi-ligament PCL-based injury or an isolated PCL-based injury. So here are our subjective outcome scores. You can see at the top the isolated PCL and the PCL with the multi-lig have a Tegner average Tegner activity score of the same, and they move to exactly the same postoperatively at a 5.0. The Lyshans are almost exactly the same postoperatively at right around 80, and the patient satisfaction was almost exactly the same at 7.5 and 7.4 respectively. Now, it's all great to say, right, we were able to have subjective outcome scores that patients were happy with their results. But earlier, that's what our single bundle PCL shows, that patients are pretty happy with those outcomes. But the difference with the double bundle PCL is that they also are effective at restoring joint stability. So here is from the same paper, unpublished data, 100 PCLs, where we had pre-op posterior tibial translation of our isolated PCLs of 8.7 millimeters, and then PCLs plus other ligamentous injuries of 11.9 millimeters. And then utilizing a double bundle PCL reconstruction, we're able to improve those levels of stability to 1.2 millimeters for PCL only and 1.7 for PCL in combination with other ligamentous injuries. And so the key here that I want you to take away is that no longer is it acceptable to have lax PCL after PCL reconstruction. There are techniques and postoperative management that really should create a stable joint environment. So this also is a paper that is unpublished of our data that we're getting ready to submit. And this is looking at multi-ligament outcomes. So this is 167 patients between 2010, 2014, and 2-year follow-up. And so you can see the outcomes here are pretty consistent with the earlier data that I've presented to you. And so what we found here is that there was no difference between the ACL or PCL-based multi-ligament injuries. So they're exactly the same for our double bundle PCL or our single bundle ACL. And that's probably surprising to a lot of people because ACLs are considered to be this technique that is routine or somewhat routine and that we get pretty consistent or reproducible results from it. The PCL is somewhat a little bit more unknown. And so in our hands, there was no difference between the ACL-based or PCL-based. And there's also no difference between medial or lateral structures. So with a PCL-based with a MCL reconstruction or a PCL with an FCL reconstruction, it made no difference in terms of the outcome. And that was the same also for the ACL. So I'm going to wrap things up here, and there's a couple of takeaways that I was hoping that you could leave with. And so that is, first of all, that a double bundle PCL reconstruction really is the gold standard and is appropriate and is effective in restoring joint stability and has good patient outcomes in terms of their satisfaction of results. The second is that irrespective of having a great double bundle PCL, if we don't restore range of motion, there are no patients that are going to be happy with their outcome. So having great rehabilitation that restores symmetrical, as close to symmetrical range of motion, is really the key in creating great results. The third point is that dynamic bracing is absolutely an integral to avoiding graft elongation. And so, in my opinion, it should be a standard kind of practice or point of care for anyone that has a conservatively managed PCL or a surgically managed PCL. And the last piece is that these are long-term injuries. It's hard for patients to wrap their head around 9 and 12-month recovery, keep their head in the game to enable them to get the best outcome. You need to create a plan. So utilizing either something that I outlined or other tools that you have, to be able to create an outline to show patients, here's where you are in day 1, this is what we're going to be working on at week 12 and week 26, and here's how we're going to get to that endpoint, is incredibly beneficial in long-term injuries. So Hopefully this information has been beneficial and there's some things in there that you're able to use in your clinical practice. I included my email address on the title page. I'd be happy to take any questions over that if anyone in the audience has any. Appreciate your time. Thanks very much.
Well, thank you very much for that, Luke. Your time and expertise is really appreciated. And I think it's amazing the sheer volume of knee injuries you're potentially seeing on a daily basis. So just in closing, I'd just like to make a few points. So we've learnt tonight that the PCL can be managed surgically or conservatively, depending on the grade and the concurrent structures affected within the knee. Historically, the PCL has had a tendency to want to heal in an elongated position, whether it's been surgically repaired or reconstructed or conservatively managed. We saw some research that Luke was involved in that highlighted the need for a brace that applies correct anatomic joint forces that vary or increase with knee flexion angle to adequately support the PCL whilst healing. We know that long periods of immobilization have unwanted side effects, such as arthropibrosis that we saw in one of the videos and associated muscle atrophy, etc. So the Rebound PCL is a brace that allows protected mobilization, a biomechanically stable and safe environment for the affected structures to heal, and it's able to optimize the healing and rehabilitation of PCL injuries. Luke's been kind enough to provide his email address should you have any follow-up questions. If you would like to arrange to find out more about the Rebound PCL and where it can fit into your clinical practice, please contact your local Össur representative, or you're welcome to contact me and I can put you in touch. This webinar will be uploaded to our website where you'll also be able to find our previous webinar on the degenerative meniscus. So once again, I really appreciate your time and thank you again to Luke O'Brien for his expertise and insights into the management of PCL injuries.